Background: transcatheter intervention in neonates present unique challenges in Bangladesh due to limited resources, unavailability of hardware, cost of procedure, low birth weight, sepsis, delayed diagnosis. In neonates, less invasive interventions are preferred because open heart surgery can be performed at few centers and is associated with a high mortality risk. The primary consideration of the pediatric cardiologist should not be whether it is possible to perform such techniques, but whether their clinical utility, morbidity, and morality justifies a non-surgical approach for their patient. Careful technique, proper planning, and safety measure reduces the incidence of complications. Spectrum of neonatal intervention: 1. Balloon aerial septostomy, 2. Valvuloplasty, 1. Pulmonary valve, aortic valve, 3. Neonatal coaptation balloon dilatation, 4. Ductal stenting, 5. Perforation of pulmonary valve, 6. Rod stenting, 7. Preterm PDA device closure. Hardwares, 1. Plan the procedure and hardware well in advance, 2. Explain the procedure, discuss strategy with colleague and technician, 3. Always try to have a plan B ready, both in procedure and hardware. 4. Minimize the number of puncture attempts and to the smallest size needed. Have a good peri-procedure monitoring. Balloon atrial septostomy, 1. BUS was first described by Rushkind and Miller in 1966 for palliation of certain forms of CHD. It is a close technique of rupturing the
foramen oval by repeatedly withdrawing a balloon tip catheter to the right atrium to left atrium. And we need to do a rapid forceful jerk. We usually use Z5 septostomy catheter, which is a dual lumen catheter, and under echocardiographic and fluoroscopic guidance. So this is the echocardiographic feature after septostomy. Neonatal balloon angioplasty is effective in treating congestive heart failure due to isolated coarctation, but provides only a temporary relief. This balloon angioplasty may be performed at a first treatment of aortic coarctation to stabilize the neonate who are too sick for immediate surgery. These procedures are not that technically difficult, but getting the femoral artery access will be sometimes difficult. And some authors have described axillary artery for this procedure. Balloon aortic valvuloplasty in critical aortic valve stenosis in neonates is very time demanding and is a difficult procedure, and usually done in intractable congestive heart failure with severe left ventricular dysfunction, often with mitral abnormalities and endocardial fibrosis. And the balloon catheter chosen according to the size of the aortic annulus, and when possible the balloon size equal to or slightly 1 millimeter go into sudden bradycardia, so your cath lab should be ready for this. Balloon pulmonary valvuloplasty in neonates is generally similar to that in older children, but the procedure is slightly more difficult to accomplish in neonates. The problem is to cross the pulmonary valve using a coronary guide artery. We use right coronary artery catheter, mostly Cook 4.1 catheter, which have 1.52 and 2.5 curve. And the second problem is positioning the appropriate size balloon across the pulmonary valve, and for which, if you are lucky enough, if the patient is having a PDA, then you can position the stiff wear into the descending aorta through the ductus arteriosus, thus anchoring the wear steadily and makes it easier to appropriate position of the balloon catheter. And you need to do a graded balloon dilatation. PDA stenting is now believed to be a reasonable alternative to surgical aortopulmonary shunt in securing pulmonary blood flow in drug-dependent cyanotic heart disease. Although PDA stenting tend to be less durable than conventional surgical shunt, this may not be a significant problem if definitive surgeries are performed at an earlier age. So before doing the ductal stenting, you need to understand the ductal morphology for planning for your appropriate catheter and appropriate approach. So the most difficult duct is the vertical duct, which arises from the undersurface of the aorta, and the next is the intermediate origin, where the duct originates from the distal arch, and it usually found in association with single ventricle situation. And the indirect duct is like after doing the procedure, is like a BT shunt, and the duct arises from the left subclavian artery. And I first did my first ductal stenting in this kind of patient. And the easy one is usual duct arises from proximal descending aorta. Those who are the beginner can start with this kind of duct. And bilateral ductus are also there. So most of the case we do the procedure under general anesthesia, and after taking the femoral arterial access, we do an angiogram, and after checking the angiogram, we plan which approach we will take. Here you can see the femoral arterial approach. We have done the ductal stenting in case of intermediate kind of duct, and also sometimes it is possible with this kind of vertical duct as well. Earlier we used to do femoral venous approach. We used to take especially top with top pulmonary atresia patient. This is a patient where we have we did the ductal stenting in a vertical duct through femoral venous approach, but this approach causes sometimes severe bradycardia and heart block. So now we are not using this procedure much. So mostly now we are using axillary artery approach, where we take either left or right subclavian axillary artery, and for the vertical duct, this approach is applicable nicely. And stenting of RVOT has been described as a palliative procedure in neonates with TOF with severe pulmonary blood flow obstruction who depend on continuous infusion of prostaglandin E1 infusion. So these procedures are also very difficult. You can see here there is very slight antegrade flow across the pulmonary RVOT and pulmonary valve, and we put a coronary stent in this kind of patient. And finally, my last slide is pulmonary valvotomy.
Your slide is just switch off, so they are not enjoying your
conclusion,
slides.
and we can do discussion.
Switch you to the discussion time.
Cardiac intervention in neonate is safe and effective, especially in resource-limited setup. It requires proper diagnosis, stabilization, and prompt intervention, teamwork, and long-term follow-up. Variation in anatomy, patient size, and poor general condition and presentation add to the challenge of carrying out this catheter interventions. Early identification and old plan catheterization procedure improves outcome. Thank you.
সুমাইয়া একটা কমেন্ট বলি আমি জাস্ট আমি বলতে চাচ্ছি এই আজকের যে সকালে প্রোগ্রাম অর্গানাইজ বাই দ্য বাংলাদেশ পেডিক কার্ডিওলজিস্ট অলসো বাংলাদেশ আইপিডিএ কিছু করছে না, ওরাই করছে। থ্যাংক ইউ এভরিবডি।